So we're going on to week 9 now, which is assessment, treatment and rehab of the lower limb. So this module's a little bit more focused on specific cases with people as well. I'm quite excited to start this one because when you're at uni, they give you a list of all the different things that you're supposed to know. So things like, let's just say, I don't know, like an ACL injury or something like that, or shin splints, and you're kind of expected to know how to treat it. And one thing that I've especially kind of dealt with the rugby is people come up to you and kind of expect you to know how to treat a specific thing, but you're not actually going to know until you've assessed them properly. So I'm quite interested in how to kind of adapt the assessment that we've done in week 2 with the specific cases as well. So yeah, I'm looking forward to getting this week done.
So one of the big things for Module 9, or one of the big assessments of Module 9, is the ankle assessment. So we do a bit of ankle in Module 2, but we're very much more interested in general whole lower limb in Module 2. Obviously, if you get a real tricky ankle, then it's important to be able to do a more detailed assessment of the ankle. So there's a few tests we use. Obviously, we've got our knee to wall that we're going to talk a little bit about today. We've got our end range plantar flexion test, which is basically a calf raise. But it's not just making sure they can calf raise, it's really making sure they can go all the way up into that full end range calf raise. Then we've got our functional ankle assessment, we've got our inversion assessment, we've got our eversion assessment. So this is where we can really start to narrow down the tissues that are involved in an ankle injury, rather than just trying to treat everything and hoping something sticks. It's just getting real specific, what tissues and what movements are affected, and how do we need to treat those. So for the knee to wall assessment, and I think most people are familiar with the knee to wall assessment, but again, just like everything else on the mentorship, it's just thinking higher level, what are we actually testing here? So I'll just use a ruler. We've got the smallest ruler in the world today, but tend to put a ruler up against the wall. Obviously you have to take the skirting board into consideration here as well. And all we're going to do is keeping the heel on the floor, Sarah, just bring your right knee to touch the wall, which is pretty good there. So all we're going to do then from there is bring the foot back as far as we can. So step back a little bit more, keep the heel down, that's it, knee to wall. And we're just going to keep coming back until it gets to the point that Sarah can keep her heel on the wall. Obviously with a patient, I'll probably do this barefoot. Nice, and that Sarah is really, really good. Now, what you'll see with patients, you go a little bit closer again, Sarah, sorry. Yeah, you can bring the foot a bit closer, yeah. So what you'll see with patients a lot of times is they get to this point and they can't quite get to the wall. Now, if they can't get to the wall, I'm really interested in where they're feeling the restriction. So a common one that we get a lot is that pinch in the front of the joint, or else it's going to be tightness in the back of the calf. Yeah. Now, if you're bringing your knee forwards, just hold it there for a second. So if they're in this position and they're feeling tightness in the back of the calf, obviously I'm thinking then, myotendinous junction of the Achilles tendon, or I'm thinking the gastroc not lengthening very well. But oftentimes, and I'm sure you've come across this area recently, is when you come into this position, they actually feel more of a pinch in the front of the joint. Have you ever seen that, where they kind of get that pinchiness in the front? Now, if they're getting that pinchiness in the front of the joint, which is compressing, I'm still very interested in what's happening posteriorly. So what's happening around the back of the joint here. So the big thing here in my experience is the ligaments. So you've got your posterior talofibular ligament and your posterior tibiotalar ligament. Now, especially after an ankle sprain or something like that. So if we imagine an ankle sprain, you go over on your ankle, tear your ATFL, let's say for example, a common one. Obviously that ligament's gone, that stability is gone. Short term, we need to get that stability back from somewhere else. So what tends to happen is the posterior ligament, the PTFL, posterior talofibular ligament, tends to tighten up to try and protect the outside of the joint. Does that make sense? And even 5-6 years later, there could still be a lot of tension in that posterior talofibular ligament. Now, that mightn't cause problems at the time, but then if they start to build up a lot of running or something like that and they start to get some ankle pain, then I'm really interested in freeing that up. And if I see a big difference between the left side and the right side, and they're getting that pinch in the front of the joint, I definitely want to assess that posterior talofibular ligament and the opposite side tibiotalar ligament. Now, to put that, kind of help you understand that, if you imagine your ankle, you've got your tibia and fibula here, obviously. Your talus here. As you're going into dorsiflexion, you need to be able to get that talus to pass underneath. Now, if these can't lengthen at the back, that's when you get that kind of joint pinching at the front. So that's why we're kind of interested in the posterior ligaments, even if it's a pinch in the front when they're going that way. And the big thing with this test is checking left and right. Normally I look for about 10 centimeters. There's a bit of research out there that suggests that's a kind of good measure. But obviously you're going to get a lot of variance with this. You get some people who can get out to 16, 17 fine, and you get some people who can only get to 5 or 6. As long as it's even right or left and they're not getting any symptoms, I'm pretty happy. It's only if they're getting symptoms or if there's a massive difference between right and left. Does that kind of make sense? But it's a really important one to check with most kind of lower limb issues if there's any history of ankle sprains or anything like that as well.